Ashley Andújar, I hope I'm pronouncing it correctly, Scott Lockard, Daryl Melvin, Daniel Miller, Maria Poepsel, Michal Rhymer-Browne, and Andrew Sakari. Let me start with and we'll go down the line as I ask the questions, and please give a little bit about yourselves as we open up our panel. The first question in an introductory context is, what is your past and current work in public health ethics, and how has that been influenced by public health ethics in your work? What your past and present and your current work, and how has public health ethics influenced your work? Ashley.
Hey everyone, I hope you can hear me.
We can.
Yes, so I have a background in emergency management. I worked for a few years for FEMA, so Federal Emergency Management Agency.
We're kind of losing you.
Is that better now?
That's much better.
Okay, so give me 1 second. I'm having some technical issues.
Can we go to Scott and come back to you?
Yes, let's try that.
Okay, let's try Scott Lockard.
Okay, good afternoon. My name is Scott Lockard. I'm the Public Health Director for the Kentucky River District Health Department. I have spent 30 years in public health, working primarily in rural areas. I have worked in Kentucky River District and also for a time in a more micropolitan area in Clark County, Kentucky, which is adjacent to the Lexington, Fayette County urban area. But I have lived my life here in Eastern Kentucky. Ethics has played a big role in my practice. I am a social worker by training, and so I always strived and looked at the what we call social justice, in public health, health equity. We really working towards that. And now my practice in Eastern Kentucky, an area where there is great health disparities, where we have some of the poorest health outcomes, poorest health factors in the nation. 1 in 3 people live in poverty, and ethics really guides so much of what we do in this area, just from the basics of looking at how we fund public health in the Commonwealth of Kentucky with a heavy reliance upon property taxes, where individuals who need public health services the most have the least local funding due to low property values and low income to provide those services. Again, always taking a big look at ethics and how that impacts our practice every day.
Fantastic. Ashley, can we get you now?
Yes.
Fantastic.
Not sure what's going on with the video, but we can get started. So yeah, my name is Ashley Andújar. I am currently a health promotion and communications lead at CDC in the Waterborne Disease Prevention Branch. But a lot of my background has been in emergency response and emergency management communications. So like during CDC, I've done, responses with Zika, with Hurricane Maria, now COVID in Puerto Rico. And I feel like every decision that I've made, in my career, ethics has played a huge role in just making sure that I influence and that I'm that lead voice so that minority populations and specifically, for Puerto Rico, that the information gets across to not only rural communities, but pregnant women during Zika, during the hurricane, we had a lot of people with chronic illnesses that needed life-saving information. So that has been always sort of like a driver for me. And during my time, when I worked for FEMA, I deployed to around 10 disaster areas in the States. And I would always, gravitate toward, making sure that Hispanic communities, again, in rural populations had, emergency response information, that they knew how to apply for assistance and all of that. So I think, it has always been sort of like a driving force for me personally.
Fantastic. Let's go on to Daryl. Now, we want to try to focus in on the public health ethics, because we know public health infuses. How does the ethical context influence what you do? And in fact, what do you do? Daryl?
My name is Daryl Melvin, and I'm a member of the Hopi and Navajo tribes of Arizona. And my people are from the Mustard Seed Clan and Roadrunner Clan, and I'm born for the Coyote Pass Clan. And what I want to share is that my life experiences have informed my work, and it's the personal decisions I made that I choose to serve my community along with other rural tribal communities, and that these choices include being an engineer and providing safe drinking water to communities and families that didn't have any, and also leading critical access hospitals and health centers as a CEO to address the health disparities and deliver healthcare services to the underserved populations. Those experiences really brought me to my current role in working with tribes and tribally led organizations on different initiatives that further Native asset control and asset management. And the work really includes addressing inequities experienced by Indigenous people through perpetuation of myths and stereotypes and invisibility issues, and really to further work on what we now see as reclaiming Native truth. And that would include changing existing deficit narratives that surround Indigenous people and promoting the sharing of strength-based narratives. And so that's the work that I do and that informs my public health lens that I use to work and to share with the panel today. So thank you.
Fantastic. That is beginning to open up the window of ethics, and that's exciting. Daniel, give us your context within the framework of what you do.
Sure. Thank you, Dr. Warren. And first, just thank you to the Tuskegee Center for Bioethics and CDC for gathering us together to talk about all of this. So my name is Dan Miller. I'm a practicing family physician, and I'm the Chief of Graduate Medical Education and Behavioral Health Integration for Hudson River Healthcare in New York State. We are a large federally qualified health center, and so I think I'm here to represent the community health center movement in this discussion. To get some to this ethical perspective, like all federally qualified health centers, we are nonprofits governed by a board of directors, and by law and mission, more than 50% of our board are actual patients of our health center. And so, we're in a somewhat unusual privilege of actually working for our patients. All community health centers provide primary medical care, dental care, behavioral health care to everyone, regardless of insurance or ability to pay. We start with this fundamental understanding that healthcare is a right and is accessible to everyone. Let me say that our own health center was founded in 1975 by our four founding mothers, four African-American women in the city of Peekskill, who recognized that there was nowhere in that community for them or their families to access competent or dignified healthcare. And so they did what they were told they couldn't do, which was make it happen. We are now, 50 odd years later, 43 practices serving 200,000 people in rural and urban environments, and with a particular focus on migrant and seasonal farm workers. Let me just say briefly, I also serve on the board of the National Association of Community Health Centers. Community health centers in this country serve 30 million people. 1 in 12 Americans get their health care in a community health center. Of the about 2.5 to 3 million agricultural workers, we serve about 1 million of them. And in closing about ethics here, let's just say that we cannot talk about rural health without talking about poverty and about racism. And I know we will get to that, and I'm looking forward to it. Thank you.
Thank you so much. You hit the money right on the money. So thank you for opening up the really powerful conversations as we proceed. Maria, your context in the context of public health ethics.
Good afternoon, everyone, and thank you for having me on this panel. I go by Sally for short, and it's pronounced Poepsel. I have been in healthcare for 46, 47 odd years, and in spanning clinical research, and my background is primarily critical care, and in the last 27 years, been practicing as a nurse anesthetist, specializing in anesthesiology and providing services to critical access hospitals in Missouri, as well as surgery centers and tertiary centers. Primarily, I'm doing now office-based surgery centers and covering for critical access hospitals. My philosophy is that as a professional, my ethics has always been to gear my efforts to be the best person possible in my work life. And in rural critical access hospitals, I'm always confronted with making ethical decisions on a daily basis, simply because we have a power over our patients' well-being, which creates a mandatory need for we to be ethical and to practice integrity. So I practice this within that culture of ethics and integrity in all of my aspects of professional life, including personal life. My experience in the last 27 years in critical access hospital are the challenges that I've confronted with in making decisions, life and death decisions, whether we should do a certain procedure, whether we should not do any certain procedure, and do we have the resources for this patient to be able to do that particular service. Or the question also is, if in fact these patients are the benefits outweigh the risk for this patient to have to undergo this procedure. So that's where I'm coming from. Thank you.
Fantastic. We're really getting down to peeling the onion and getting down to some of the really critical questions. Michael.
Good afternoon. It's Michal Rhymer-Browne.
I'm sorry.
No problem. Common mistake. I've been Michael for all my life, my other name. Yes, but it is a pleasure for me to be here today representing the beautiful U.S. Virgin Islands. We are proud people here in the territory, and we are U.S. citizens in the United States umbrella of territories. And I believe that my position here today is to really highlight the need for us as U.S. territories to have equitable access to public health, especially in our areas, in our territories, which are so far removed from the U.S. mainland. My background has been social services for about 28 years now. In the last, I would say, 10 years, I became involved specifically in the area of Medicaid management. And here is where the ethical experiences have been many. I was reminded so much about the ethical decisions that we have to make, and very coincidentally this morning, about 6:30, I heard my WhatsApp text ring, and it was a mother who asked if I remembered her. And she said, 7 years ago, you helped to save my baby's life. And I remembered that this child who they told us would die, and not to send him to Florida for assistance because he would die in a matter of a couple days. Well, I believe because of my training, because of my spiritual background, I'm also a pastor, that where there's life, there's hope. And with our Medicaid funding, limited as it was and still is at the time, we were able to send this young infant to the state of Florida. And today I was able to see this 7-year-old young man who at that point, they did not even think he would survive 7 days. I share that account because I believe it's ethical decisions like those that come up for an agency like ours as we administer Medicaid with some of the lowest funding that we have in the United States. There continues to be inequitable allocations to the territory in the area of Medicaid, which is so critical for the healthcare access for our low income, our elderly, our children, our disabled. And so it is a passion of mine, professionally and personally, to be the voice for those who are voiceless and to stand up for those who may not be able to stand up for themselves. In the last year, I had the opportunity to go to the US House of Representatives twice to represent the US Virgin Islands and the territories to speak up about the inequity of the treatment of territories when it comes to Medicaid and public health access. So I really believe, and I'm very proud to be able to sit in this seat and to be able to not only administer the Medicaid program, but look at that program as a way that we can help our citizens, and we are citizens of the United States. Unfortunately, many of the practices and the federal funding is not equitable. And so my time here today, I just want to be able to share some of the challenges that we face here in the United States territory. But it's not all bleak. We are pushing forward with using the funding that we have been allocated. And I believe if we get the support of our federal government, we'll be able to do some really great things in the next 5 years.
Thank you for sharing that really ethical decision-making and how that's had a very positive outcome as you saw that young child come back to tell you hello. Thank you so very much. Andrew Sakari.
Yes, sir.
Because of what you do, what has public health ethics, how has it influenced it? And what do you do?
I'm a rural sociologist out of Pennsylvania, Penn State, and I've been studying the rural Black Belt for the past 25, 26 years. I study poverty, rural poverty among Black people in this area. And as we all know, Black Belt counties are one of the forgotten or left forgotten counties in America. When I studied poverty in this area, what guided me, or what is always on my mind, is social justice, participation, effectiveness, affordability, and accessibility. Do these people have access? Can they participate in things that make their life meaningful? You know, equity has to deal with everyone should have a stake in the things that make life meaningful. The people in Black Belt counties don't have the resources. They don't have the human power. They don't have for example, they don't have hospitals. They travel up to 70 miles for rural health care. Okay? All these things are very, very important. Consequences of things that affect their life that they have no control over. And yet they are part of Americans, or they are Americans, or they are Americans. But yet they have problems.
Dr. Sakari, tilt your screen down a little so we can see your face. There we go.
Can you see me now?
Yes, perfectly.
Okay. Yes. So I studied these communities and societies and the families that are raised in these societies that are very poor, that have no say in what is happening to their communities, have no say in what is happening to their lives. And you all know, as you deal with ethics and public health, you deal with social justice, participation, okay, effectiveness of what is happening in these places. And I've tried to look at that and bring the applied to the public perspective by attending national conferences. I've been to Washington, D.C. to talk on behalf of Black Belt people and the county as a whole and the rural Black Belt South. In addition to studying Alabama, I've looked at some Black Belt counties in Georgia too. And Dr. Warren and I have looked at that together, some black belt counties in Georgia. And what I found out is that they are similar. There's no distinction. When I look at the rural schools in Georgia, in black belt counties, they have the same problem that the ones in Alabama have. So, ethic framework, public health ethics, I use that to carry out what is happening in these communities.
You all can see we have a very powerful panel, and I'm not going to waste time by going through the order. I'll raise a question and have the panelists respond as they see fit. We've heard about some challenges, the dilemma, the urban, rural, the ethnic, racial, geography differences. Give us some suggestions on how do we deal with them? What do we do besides define the problem? What do we do to resolve it? So any of the panelists that you feel free to chime in.
So Dr. Warren, this is Daryl Melvin. I just want to share a little bit of information with the participants on this, here in this forum. And one of the things that we do in Native communities that has been really a game changer, it's been information that's just come out in the last few years, but First Nations Development Institute has conducted a study which is called Reclaiming Native Truth. And it's a nationwide study that looked at surveys, interviews, and analyzing social media posts. And what it did is it helped uncover some of the deep-rooted biases and toxic assumptions that people held about American Indians. And really, these are the same individuals that are leaders in, say, our court systems and our legal systems, our law enforcement, government, etc. And some of the findings were that most Americans learn about Native American or American Indian history from elementary school and high school, or maybe through pop culture, movies, television, etc. And what the findings showed was that only about 1/3 of Americans believe that Native Americans face discrimination. And what this really shows is that discrimination for our population is underreported. And of course, that leads to the biases that we're talking about today. And the biases can be introduced then into the policies for the institutions and the programs in healthcare that we're talking about. Additionally, 40% of Americans believe that Native Americans actually don't exist in our community today. And part of that is because the Native American narrative is actually dominated by narratives of non-natives, individuals talking about our communities. And so really, this issue of invisibility is destructive to the Native community population and youth. And it underpins some of the non-access to the healthcare services. It's a driver for the need to really have conversations, which we are in currently in America, about race. And so invisibility for Native American really is the modern form of racism.
Absolutely, absolutely. Other panelists, I'm sure he's opened it up.
I think we need to give them the resources.
Okay.
They are public, coming out in public and saying that Black Lives Matters is a good idea. But Black Lives Matters, but they need the resources, they need the power. We need to put them in control of their own communities. We have to make them the effect, they are the one to change their communities. Give them the resources, give them the power, put them in the driver's seat, let them drive the car. But the car will not ride or it will not run without the petrol.
Absolutely.
Okay.
Another panelist, we getting warm, come on.
Yes, I was about to say that for the U.S. Virgin Islands and other territories, I really agree with Mr. Melvin. We need to bring knowledge to those who may not be very knowledgeable about who we are. Here in the territories, yes, we are U.S. citizens. Yes, we have strong cultural and strong sense of community, But I believe that it's important for us to raise our voices. And that's why I took it so seriously to go to Washington, D.C. last year to raise the voices and let them know that the territories, we do matter. We have serious health issues. And as U.S. citizens, we should not be neglected. I remember one of the representatives said, "And in your country," and I said, "Yes, my country of the United States of America." And it was so important. And I knew he wanted to fall down behind the desk when he said that. But I said, yes, my country of the United States of America, who I am so proud to be an American, needs to be aware of the plight of the territories. We're not asking for a handout. We are asking to be treated like any other U.S. citizen that is on the mainland. If I go to the United States, I am a U.S. citizen. I'm able to get the health care that I need. Here, if I live in the territory, I cannot get the services that I need. I am not able to access much needed Medicaid or sometimes Medicare benefits. I don't have SSI. All of these are benefits and opportunities that are available on the U.S. mainland to citizens and should be available to our U.S. citizens in our U.S. territories. So my advice is we must raise our voices. We cannot be silent.
Is this a rural problem, or is it just a problem for the Virgin Islands? Some panelists, is she alone with this challenge?
I don't think so at all. I'm in rural Appalachia, and we are an area that has often had our resources extracted and the people forgotten about. And we see that frequently. So we spend a lot of time educating policymakers about what our needs are, spend a lot of time trying to work and bring together our community partners. In public health departments, we're really conveners now. And we bring together our FQHC partners, our healthcare partners, our government partners, and we remind them of the ethical issues that we deal with health disparities and inequities in our communities. And we also, too, sometimes have to remind our residents themselves who now have developed a very fatalistic outlook because of living in poverty for so long. One of the groups we partner with is SOAR, Shaping Our Appalachian Region. And they did a public relations campaign targeted at the people of Appalachia, which said, Appalachia, there is a future. So really trying to educate the people themselves and to improve their mental health and well-being, that they should feel good about themselves and the area in which they're from. So it is a constant, never-ending struggle for us to make those empowered aware of what we're facing every day and giving them solutions as to how they can support us to improve the situations we face.
Fantastic. I heard the word FQHCs, and Dr. Miller, let's talk about rural federally funded community health centers. What has been your experience?
Thank you, Dr. Warren. So I think we're, as you've been saying, we're getting into the meat of this now. As a clinician and as providers of healthcare, one of the things I think we all recognize is the importance and the power of properly understanding and naming what it is we're trying to improve and help and work on. And I think words here and definitions are really important in our work and in all of our work. And so for a minute, I'd like to come back to this concept of the social determinants of health that we've been talking about. And I think we all recognize that probably about roughly 50% of the factors that affect our health are not just the healthcare we provide, but really kind of what's in our zip code and whether that's rural or urban. And these are issues of education and housing and employment, income. And I think when we go a little bit deeper into that concept of these social determinants, and when we do it looking with an understanding of institutional and systemic racism, we recognize that those social determinants of health are the same systems that we found that mediate the effects of institutional and systemic racism. And as we look even closer at them, at banking and housing and mortgage systems and education and healthcare, you know, when we look at our history, which isn't so old, we recognize that when these systems and institutions were created, they were created with the intent and purpose to be inequitable. And that's, they were meant to be inequitable. And so, you know, you challenge us of what do we do? I think this is crucial because when we, you know, as all good people are going to work hard within these systems, our outcomes are still inequitable. And they're inequitable, I think, because this is how these systems were designed, and they were designed really well. And so just to close this piece, I think naming is important. And coming back to the social determinants of health, I've really come to believe this term itself is a euphemism. It's a euphemism for poverty, and it's a euphemism for racism. And it makes us realize that when we do what we do, and in our world, when we treat the illnesses we treat, when we see the people we see, and the interventions we make are enormously powerful. But at the end of those days, what our patients are actually dying of is racism and poverty. And once we understand that, then I think we can get to work. Thank you.
It's a powerful statement. I heard Martin talk about discrimination, and I heard you talk about racism. Mm-hmm. Are they the same, or are they different? Or do they just impact upon certain populations? What of you powerful panelists, try to unpack that for us.
How much time do you have?
I'll cut you off if you get to going too far. But I know it's hot. So, come on, panelists, let's go. This is the time.
If I could, I'd like to comment on the questions about this institutional systems that we currently have. And in Indian country, you're going to see themes about the institutional inequities, and that, you know, what we see for our communities are the Indian Health Service and the Bureau of Indian Affairs actually are the education, traditionally the education and the health systems for Native Americans. And I think it was previously said is that they're perfectly designed for the results that we get, and they're national in focus. And so with over 600 tribes across America, both federally recognized and state recognized, the solutions really for creating the education and the healthcare systems are local. They're place-based. So within IHS, as an example, to have transformation occur is to ask the question about what their mission is and what it could change to focus on the place-based solution, or mandating that, say, local tribal solutions are inherent in the fabric of local healthcare systems. So the other way, if you look at the pathways to addressing some of the inequities, would be as an example for public health surveillance. When you talk about COVID-19, is why are Native people misclassified or listed in as other category? You know, and creating systems should be the response to more accurate reporting, you know, to create opportunities that will allow for addressing these systems that create the inequity, you know, and really question systems that are self-reinforcing, so that we can include different criteria that can help address those structural and institutional inequities that we see.
Mm-hmm. Now, I'm challenged too, because what I'm hearing sounds urban and rural. Are there some uniqueness about rural that impact in greater ways than they do in other areas? And maybe not. I grew up in the urban cities, so somebody share their perspective about that.
There are differences, big differences. In rural areas, you know, all the population are scattered all over the area. They are sparse. So in that case, bringing services to this area becomes difficult. And the services available, they have to travel far and wide to have access to these services. That in itself creates a burden on rural families. Some of them don't have the transportation. They don't have the financial resources. They don't have the human resources compared to urban areas. So there's a big distinction between rural and urban when it comes to hospital services and other economic services that are available to make life meaningful.
Other panelists?
And this is Ashley. To add to that, for example, Puerto Rico, you know, is an island, and I'm sure USVI can relate to what I'm about to say. But for example, during Hurricane Maria, where you have, you know, not only metropolitan areas that are heavily affected, in the rural communities is more so, you know, the situation was more so dire in terms of access to just basic things like food and water, like, you know, electricity and healthcare access. And, you know, going back to the idea of racism, I think colonialism, you know, as a whole for us in the territories is a big factor that plays into, you know, why we're underfunded or why, you know, our rates in chronic diseases are much higher. So yeah, I think for, like, if you compare the territories with the states and the rural areas in the states, it's a little bit more so dire, and, you know, the poverty rates are more extreme. So I think, at least from the perspective of the islands, that's something that also we need to take into consideration.
And I
would say that, oh, go ahead.
I was gonna say, I do agree, Ashley. Being here and from the territories, I think back historically, many territories, we were taken into the umbrella of the United States because of military distinctions and where we were located geographically. And I believe we were adopted into the family of the United States. However, I do not believe there was at the time any anticipation that we would get equal rights. And so we were set up with certain laws, rules, and regulations that have marginalized us as US citizens here in the US territories. And so I believe in the public health aspect, this is glaringly so. As a matter of fact, our delegate to Congress, Delegate Plaskett, has introduced, and she introduced this in February 25th, 2019, an act calling for equity in public health access called the Territories Health Equity Act. And that has yet to move, but eventually that's what we as the territories need to gain equity. We will have to challenge the preconceptions. We will have to help to inform that no, our country is the United States, so we can remove these barriers that have been put up for us and that have marginalized us and given us less than stellar services and resources for our territories.
Please keep reminding us, because some seem to forget, maybe unintentionally, but they seem to forget. Maria, you were ready to say something.
Yeah, I was going to say that many of these challenges that you find in rural areas are more magnified compared to the urban. The dimension of transportation, lack of access, lack of health, educational on health issues, inadequate health coverage that nobody has mentioned yet. Many of these challenges are magnified in the rural areas. And when we go back to the solutions, I might say that I've had an opportunity to work in the last 4 years with the Secretary of Health and Human Services as a member of the National Advisory Committee for Rural Health and Human Services. And that's exactly what we looked at from a policy standpoint. We look at all the social determinants of health as the main framework when we look at the rural issues and challenges, whether it's be maternal or obstetric care. There's so many obstetric deserts now. There's so many healthcare deserts now because many of the rural hospitals have closed. We have also addressed opioid abuse. We have also addressed adverse childhood experiences, the ACE experiences. Many of these issues are very complex and can be resolved or can be addressed through our national policy. And so that's what we did with the National Advisory Committee for Rural Health in the last 4 years. And many of these recommendations have been implemented. Not all of it, because many of them have to be within the purview of the Secretary of Health and Human Services. But I would say maybe 50, 60% of them have been implemented.
We were intentional about trying to get some geographical diversity in our rural panel. Are we finding anything different or unique about these rural areas? Are there some conclusions that we can draw about rural areas, northern rural areas, southern rural areas, Virgin Island, Puerto Rico? Are there some common lessons or messages that we should be sharing?
There are common lessons,
Makes a
I
difference.
would say.
Let's hear.
The race composition of these rural areas makes a big difference.
Okay.
Right.
So
I'd like to just comment that, you know, when you start talking about how to address some of these issues and the ideas or concerns that are raised, some of it would really looking at the systems that we currently have in place and those systems that are imported into the rural communities. So, for example, when we're living in a rural community and we have an institution not unlike what we represent here today, asking the question of if we are going to put positions, whether they are board positions or professional positions, as part of changing that system, can we ask questions, are there essential experiences that should be required, that challenge requirements, say for having certain degrees that might exclude participation for rural communities. So having that representation is important. And as I mentioned, as a former CEO in healthcare and critical access hospitals, I know the question came up with medical students and residencies. And how can we get residents to really look at rural communities as opposed to some of the other opportunities they have in urban settings to come out? And what are some of those experiences in working with Indian communities? The values, the culture, the language, and the history is important. And if you can get a medical student to come to a rural community and experience what that's like, the likelihood and the probability that they'll practice medicine in rural communities is much greater than if they take a residency in another location. So those are some of the solutions that I think can be looked at to change some of the systems that we currently have.
I want to go back to the logistics here, as was brought up earlier. I think it's a commonality among a lot of our rural areas that we have basic infrastructure challenges. Here in the COVID-19 pandemic, as we've shifted a lot to virtual meetings, telehealth, things of that nature, our rural communities are the ones that have the least capacity to do these things because of poor bandwidth, poor internet. In my area, we still have 3G cell service, and because of these beautiful mountains in Appalachia, we have great areas with no cell service. So we've seen a huge push to upgrade services as schools have gone to a virtual format. And I think right now we have a tremendous opportunity. You know, I have a mentor who always said, never let a big crisis go to waste, capitalize upon it. And the COVID-19 pandemic has shown us and really brought to the forefront some of these challenges we face. And we need to utilize any funding we can access right now to build our infrastructure, not just to respond to this coronavirus pandemic, but to really position us better for whatever else comes down the way, to build up our IT infrastructure in our schools. We're a lot of areas here in Eastern Kentucky, they're actually putting internet in children's in residences for homes. And so there's just lots of opportunities, and we have to be prepared to capitalize, work together to make sure that we can take advantage of the opportunities we're given now to use that to benefit our populations.
Folks, it appears to me that maybe we lost Dr. Warren's connection.
Dr. Warren, are you back on, Dr. Warren? Okay. Well, hopefully he will be able to come back on in a few minutes. What I'll do while we're waiting him, we've received several questions, very good questions that I'd like to go ahead and ask the panel. One of the questions we receive, and again, this is open to any one of you who would like to respond, is that one of the questions was, we appear to be kind of focusing on health equity, and could someone talk about addressing the parallels between health equity and ethics? Looking at it, are they one and the same? If not, are they similar? And what are the differences?
Craig, if I might start.
Maybe I could respond to that, just in talking about, for example, the pandemic and COVID-19, and talking more about not just the health equities, but the inequities and how it relates to the ethics. So I was provided a tour of time as the public health official for the Hopi tribe, my tribe, and Hopi and Navajo were severely affected by COVID-19. We had a higher new incident rate than the state of Arizona and the nation a month or two back, and have recently been able to get it under control. But in experience that for Native communities, we experienced a huge loss of our elders, you know, our cultural thought leaders, language holders, matriarchs and patriarchs for the communities. And additionally, the isolation of elders and our families and communities had a significant toll. And you look at our fragile economies and the loss of income, it exacerbates the hardships that you have in these areas of food deserts. And so when you talk about the inequities and the ethical dilemmas, how do you respond to whole communities that have these lack of resources or awareness? When we talk about invisibility, the awareness to be able to address questions on how do you solve these inequities if you can't address the ethical dilemmas that we have that underpin the issues that we see.
Okay, thank you, Daryl.
Daryl, following that, if I might, Craig, you know, I think, you know, as you're saying, and to your question, to the questioner's question, you know, it seems to me when we talk about inequities, again, it's a word we've gotten used to, that, you know, we're really talking about people dying more than others, people being hurt more than others. And there's a fundamental ethical question here for us as a society and for us in what we do, which is how many of those people dying, how many family members and, you know, et cetera, is acceptable to us. I think we often in this world end up managing inequity. And it's fundamentally, I think, unethical and unacceptable for us to look at this to say, you know, these inequities, you know, on a basic level are somehow okay. They represent a deeply unethical aspect of our culture that needs to be addressed. So that they're not just numbers, obviously. You know, we're talking about people and people's lives.
Mm-hmm.
Thanks.
Okay. Thank you, Daryl. Thank you, Dr. Miller. Okay, another question we received was, we spend annually around $3 trillion on healthcare services, which could have been prevented. How do you address preventative services in rural, invisible areas where early access is a challenge? And again, this question is open to any panel member who would like to respond.
Getting funding for prevention is always one of the biggest challenges. I've done a lot of work in advocacy with our state legislature, with our federal federal policymakers. And it's one of those things, when prevention works at its finest, you don't know it's there. The majority of people do not. And whenever prevention is not working, just like right now, we have a pandemic and people are like, well, why didn't you do something about this? And now we're trying to make very political something as basic as wearing a mask is becoming a political statement in our country. So again, I think we go back to really having to educate, and we're constantly advocating for resources for prevention. First, we have to educate with policymakers that there's a difference between preventive health and health care. They all try to lump us together, and focusing on prevention, it's such a challenge because so many people just have struggled to see that, and they think because we're putting money into health care that we've taken care of all the preventive health needs. So it's a constant ongoing battle where we're educating, we're trying to inform policymakers, and then it gets back to that ethical discussion we're having here is what is the acceptable level of death? I had a policymaker when I was doing testimony one day, just point blank said to me, why should my constituents in my urban area be worried that people in your rural area die 10 years sooner than they do and have a 10-year shorter life expectancy? And so it's just like, okay, well, you know, there's basic ethics involved here, and we should all, some of us take for granted, we should all have those concerns and care about our fellow citizens and non-citizens and just fellow human beings as such. But it's a constant battle to educate all the time about that.
I'm back.
Okay.
Oh, welcome back.
Okay, I seem like we talk about rural America. I feel like I'm in rural America with this computer.
Yeah.
So I've missed some powerful conversations, but where are we?
Got one. Since you all, we started with some of the questions that we had received.
And, oh, great.
Yeah, and I don't know if let's see. Looking at time, we can continue with those questions, or did you want to ask another questions for the panel from that you were going to bring up?
I guess what we want to leave some time for questions. That's if there's a closing thought from the panelists, let's hear that, and then we can continue with the question from the others on the audience. Okay. Okay. Let's start with our panelists, and just what are your concluding thoughts that we can go forth? Because I definitely need to listen to the tape so I can pick up what I've missed. But give me your thoughts in terms of what's the take-home message you want the audience to hear from this panel.
I believe that it's very important for us to realize that public health and access to public health and having it be so unequally distributed, especially in light of our rural and our territories, the Commonwealth of Puerto Rico, is really creating a lot of ethical dilemmas. We have to, on a regular basis, decide on which resources to place where. And these bring us into some very large ethical decisions. And I know here in the territory, the prevention aspect is a really big part of what we believe we need to do to firm up our society. That if we invest in things like dental health and prevention for children, that we don't have to invest in $25,000, $50,000 in serious surgeries and dental surgeries. If we promote mental health and good mental health and prevention in that area, that we don't have to spend the excessive dollars sending some of our people out into institutions outside of the territory to the mainland. So I believe that if we as a people, United States citizens, really realize that all people deserve to have health care, all people deserve to be healthy and have a good sense of well-being, that we will invest what it takes to ensure that all of our communities are treated equally. And I really just appreciate the opportunity to share some of these thoughts today on behalf of the U.S. Virgin Islands.
Let me push the envelope, because what I'm hearing sounds like classical public health. And how are you distinguishing, if you are, from public health ethics? I've been in public health for too long to even recount, but that sounded traditional public health. How is that public health ethics different? If it is, it may be a false assumption. Public health is public health ethics. Why do we distinguish? Our previous sessions, people were asking, well, where is the public health ethics in this conversation? Because it sounds like public health, and maybe there's no difference. Panelists?
Ethics should guide our public health practice. And if we're going to be true public health practitioners, there is always an ethical consideration. And it is incumbent upon us as practitioners and working with agencies. There's a question about cross-jurisdictional sharing. Resources are so scarce now, it is the time for competing with each other is over. If we are truly practicing ethically, we should be working together. We should be collaborating. We should be partnering. If my FQHC partner can provide a clinical service better than I can, I need to get out of the way and let him do it and let me focus on the communicable disease, the epidemiology, and convening partners. Our academic partners needs, a key question needs to be fundamental to every piece of research that is done is how can this translate to improving public health practice so it can improve the lives of the people we serve. I would say ethically we need to do research that improve the lives of people. I'm a big practice advocate. So to me, you cannot practice public health without practicing it ethically and do it the way it should be done.
Fantastic. Now, okay, another panelist, in your closing remarks, see if you can make that distinction as our last colleague has just done.
I'd like to comment that, in just closing, that some of the ethical dilemma that I've been trying to bring to the forefront about the issues of invisibility. And in our case, my case, it's about Native communities, but really it's about rural communities as well. Rural communities not being represented. And so for me, part of it, when you talked about addressing the ethical dilemmas, it would be when you see a chart of some state health department or national health data set, and Native people are not included, I think you have to ask the department or organization why it's that way. And are communities and small populations lumped into some other category? We shouldn't have to have that. If there are panels, and I appreciate the fact I was invited to today's panel, but if a Native perspective isn't included, I think it's incumbent to ask the question and suggest that someone be included. And I would offer, if you don't know somebody, you can contact me or really any Native-led nonprofit and get referrals. And then finally, if you sit on a board or advisory panel and there's not a Native voice at the table, and ask why. There's this a tired and a false narrative out there that there's a lack of talent and expertise in public health or medical fields. And that's just simply not the case. There are lots of Native American professionals carrying out the public health and the healthcare work every day. And so for the healthcare community, those folks out there listening, I just want to leave with something that I just recently read from Wilma Mankiller from the Cherokee Nation. She said, as we do our work here, the secret to our success is that we never, ever give up. And I think that's the important message for addressing these ethical dilemmas that we face as public health officials. So thank you.
Fantastic. When I was working at CDC, I spent some time with the American Indian Physicians Association and Dr. David Baines. So I hear you. We're there. Another panelist, including remarks.
Yeah, I wanted to piggyback a little bit of what Daryl said. I think representation is key to, bringing minorities like us to the decision-making table. I think that's one of the areas that a lot of times is lacking, and it's why, we don't see, data being captured in terms of surveillance or just, the train of thought, for people to think about the invisible communities needs to be at the table and needs to be part of that wider conversation so that we can put, solutions and have strategies in place to reach, minorities, to reach rural communities. I think it's all intertwined, and it's also speaks to, you know, the need for, you know, universities and federal agencies and health departments and local health departments to have, you know, a pipeline in place to bring those minorities and to build that capacity, you know, to increase just representation in public health. So I think that's my main takeaway, is just to, you know, have a pipeline in place. You know, universities that are out there listening, I think it's super important to bring minorities into public health so they can, you know, be the workforce of the future that can really shape up these ethical issues. So
thank you, thank you. Another panelist.
Along with that, what she just said is we need to bring them in by providing them telemarketing, and in providing them
Telemedicine.
Telemedicine, they don't have internet access. So that's another resources that we need to give them. They have to have access to internet, broadband services. A lot of these places are not wired. They are not connected to the mainstream America. And that is affecting them a lot.
Fantastic. Other panelists, we're getting some good take-home messages. Don't hold back.
I think that public health and ethics are not mutually exclusive, because you have to have ethics as your foundational requirement to practice public health. Everybody has already mentioned that many factors, such as economic, infrastructure, cultural and social differences, educational shortcoming, and the very lack of recognition by our legislators, contribute to create these healthcare or public health disparities. And that impedes our rural Americans to struggle to, you know, to lead a normal, healthy life. They have every right to lead a normal, healthy life. And if we can address all these multiple factors, and we can help minimize those public health disparities or inequities.
Thank you. Other panelists.
Dr. Warren, if I might, you know, you asked us in a few different ways of how ethics here applies to rural communities as opposed to urban, and what our closing thoughts are. And for me, a lot of this comes to kind of reframing our perspectives here. We've talked about inequities and outcomes, and I think one place to start is what do we do when we look at the graphs? You know, we all see the data of the discrepancies in life expectancy by race, by poverty, by income. You know, we've seen them for years. And the question, I think, becomes, what do we do with that and what's acceptable? You know, if we took an analogy to the airline industry and looked at, you know, lives lost in crashes between one airline and another, if there was a huge discrepancy, we wouldn't accept it. We would just say, you know, either you can't fly or we got to fix it, period. Somehow we come to accept this. So, you know, beginning with rural communities, I think there are differences in rural communities. We've talked about transportation, we've talked about access. I think there are times we need to just recognize that the ways we do things often don't work in rural communities, so we need to do them differently. And, you know, for us, that means, you know, recognizing that rather than expecting people to get transportation and come to our offices, we need to get a mobile van and go out to the farms and partner with the farmers and the farm workers and say, you know, we're coming to you because we know you can't get to us. A colleague of mine put it to me of saying, perhaps we need to reframe that this is not about a hard to reach population, but maybe it's about how we're creating hard to reach services. And so we need to, you know, we need to switch our mindset. For me, in closing, you know, I want to kind of come back to some concepts I think, Dr. Zakeri, that you were bringing up, which to me is to recognize that our patients and our communities, that they're the experts of their lives, not us. And certainly if we're talking about communities of color, certainly not people who look like me. So we need to ask and we need to listen. In closing, you know, I've been struck for years by a statement from Ron Chisholm, who's one of the founders of the People's Institute for Survival and Beyond, who teach and organize in anti-racism. And Mr. Chisholm for years has said, we're not suffering from a lack of programs or a lack of services, we're suffering from a lack of power. And you know, a fundamental difference here of where interventions need to be made.
And thank you so much. Now we as every panelist had something to close on.
Yep.
Okay, well we've been fair. Let me close with a couple of thoughts. One is that I have been honored to listen, even when I was cut off, to this panel. You all have been very powerful. And I think we've seen some distinct rural circumstances that ought to be recorded and shared nationally. And we intend to do that. Every year when we conclude this public health forum, we have the proceedings published in the Journal of Healthcare Science and the Humanities. So we're going to reach out to you and hopefully we can get you to put your thoughts to paper and we can then publish it. This has been a very fantastic panel and the experience has been a challenge, but it's been a great one. And I will turn the session back over to Captain Wilkins so we can close and have our break. Greg?
Okay, thank you so much, Warren. And I'd like to take my hat off to this great panel. Thank you for your time today in response to some of these very deep thought questions that was brought up by Dr. Warren. We appreciate your participation in today's forum. Thank you.